Hello, good afternoon, everyone, or good morning, depending on where you're joining us from. Welcome to everybody, and thank you very much for attending our panel discussion this afternoon for frontline workers today about nitazenes, or potentially interchangeably referred to as nitazenes. I'm Rita Bryan. I'm the Senior Project Officer at Penington Institute. So we're a not-for-profit organisation focusing on supporting cost-effective approaches to maximise community health and safety in relation to drugs, and that includes pharmaceuticals and alcohol. Um, I'm joining today from Wurundjeri Woiwurrung country in Naarm, Melbourne, Australia, and I wish to acknowledge the traditional custodians and owners of the lands where I live and work and pay my respect to elders past and present, as well as acknowledging the traditional owners of the various lands where our audience is joining us from today, mostly across Australia, but I know that we've got some people joining from New Zealand and elsewhere as well. The format for today is we will have an approximately 90-minute session. We'll have 3 presentations from our panelists, followed by a facilitated panel discussion, and then some time for audience Q&A at the end. So we encourage you to use the Q&A button, the function today, and we'll aim to get to as many of your questions as possible. Many of you have already submitted some questions when you registered, and I know that our panelists have worked really hard to try and cover as much of that content that you wanted to know as possible. I do also would like to just take a moment to acknowledge that the content we're talking about today will include information related to overdose deaths and or injuries and the circumstances that have led to these. We recognise that this subject matter can be particularly challenging and can trigger an emotional response for some people. And we're a little over a week away from International Overdose Awareness Day, which is an annual international campaign to end overdose. And remembering and paying tribute to people who have lost their lives or have been injured or harmed or affected in other ways by overdose is a really important part of Overdose Awareness Day. So with that, I'd like to acknowledge the grief that this can bring to the community and honour some of those people who are tirelessly working at the front line to support other people affected by alcohol and other drugs. And with that in mind, I really want to acknowledge everyone in the community who has been affected by overdose, and also just encourage everybody to just be mindful of your own and others' safety and well-being, particularly at this time. So in some ways, the order of proceedings today will be a little bit chronological. We will start off with Tony Duffin, the CEO of Liffey Drug Project in Ireland, where there was a cluster of unexpected nitazene overdoses in November 2023. And then we'll be followed by Chris Rintoul from Cranston in the UK, who will speak from the United Kingdom experience, and then followed by Catherine Izawadi, who will give us some local insights about the emergence of nitazenes in Australia and a clinical perspective and so on some of the presentations that we've seen. So before we start, I just want to address why we're talking about nitazenes, what they are. They're a class of synthetic opioids. They're a very strong opioid receptor agonist. So they range quite a lot. Individual drug analogues range quite a lot in terms of their potency, some as strong as 100 times stronger than morphine or reportedly up to 100 times stronger than fentanyl. While these different analogues are structurally different from fentanyl and heroin, their psychoactive effects are quite similar to those of other opioids. And it's thought that maybe the reduction in opium production in Afghanistan has probably resulted in increased production of synthetic opioid analogues like nitazenes. And they are cheaper and potentially a cheaper and easier product to manufacture as substitutes to the opium-based heroin products. It seems that they've become more readily available on international markets following changes to fentanyl production and supply regulations, particularly in Northern America and China. And we know that they first emerged as a drug class of concern in around 2019 in Europe and North America, and were first detected in Australia in 2021. We know they appear in various forms, and I'm sure the panelists today will speak to you a little bit more about what their experience have been. And they can be mixed with a range of different substances combined with other drugs and appear as adulterants or substitutes or contaminants in products like heroin, benzodiazepines, and even stimulants like cocaine. They can also be obviously therefore used intentionally, but also unknowingly if they do appear as contaminants. And I think it's the emergence of nitazenes in non-opioid substances that's of particular concern, as people who aren't intending to use an opioid product may not be aware of the signs and responses to opioid overdose. And we're seeing increasing detections of nitazenes in the unregulated markets, internationally and overseas, and growing reports of harm from their use, which we're going to hear a lot more about today. Locally in Victoria, we know that the Department of Health issued its first nitazene alert in June 2022, and more recently in July 2024, following serious harms as observed across Melbourne, associated with a white powder that was reported to be presented as cocaine that actually contained a protonitazene. And we know that the Victorian Coroner's Court has released a warning earlier this year that since 2021, there's been at least 16 fatal overdoses in the state involving nitazenes. So that's why we're talking here to talk about it today. We're hoping we can answer some of your questions. Without any further ado, I would like to introduce our first speaker, who is Tony Duffin, as I said, the Chief Executive Officer of Liffey Project, or Liffey Drug Project. That's an organisation that reaches people who are often taking a range of different drugs, sleeping rough and experiencing mental and physical health difficulties in Ireland. Tony's also the chair of Ireland's Strategic Implementation Group 5, which is a subcommittee within the National Drug Strategy structure, and has played a key role in opening Ireland's first emergency accommodation for young people who inject drugs, as well as the provision of Ireland's first wet residential service for entrenched street drinkers, and successfully advocating for legislative change to allow for the existence of supervised injecting facilities. And of course, championing the decriminalisation of people who use drugs. So, Tony, when you're ready to share, we're really delighted to have you on board. Thank you so much for coming along. And we will hear a little bit more about what's been happening in Ireland.
Thank you. Firstly, thanks for inviting me to join you all, Rita and Chris and Catherine, and the webinar delegates. It is a privilege to be here with you today. I hope you can all see the screen. On the subject of the supervised injection facilities in Ireland, we will have first one. Merchants Quay Island colleagues will open the first one before the end of the year. So that's something that we're looking forward to in Dublin. But today I'm going to give you a quick overview of nitazenes, and particularly a case study from Dublin. And yeah, I'll go straight into it. This is going to work for me, I hope. Oh, it's not moving. 1 second, sorry. Where's that? Oh, there we go. So yes, important to give you a little overview of Ireland. Just some quick stats here to give you a sense of the latest, I suppose, drug trends. We in 2023 we had 13,104 cases of people being treated for problem drug use. Interestingly, the highest annual number recorded, and an increase of more than 1,000 cases compared to 2022. Almost 4 in 10 cases had never been treated before, and cocaine was the most common drug reported, 1 in 3 cases, followed by opioids, mainly heroin, cannabis, and benzodiazepines. Ireland has a polydrug use problem, and nitazenes and other synthetic drugs are only adding to the problem. In terms of overdose in Ireland, we had a citizens' assembly on drugs use, and I would say to you, just if anyone is interested in a very good process of deliberative democracy, have a look at the Citizens' Assembly on Drug Use report, which was published around January of this year, but it went to government last October. But in that you'll find some interesting statistics, including the 2020 poisoning deaths, which is, so for 2020 we had 409 poisoning deaths, and so more than one a day, the equivalent of more than one a day in Ireland. But also in terms of non-poisoning deaths in 2020, we had 397, tragically, hanging being the most common non-poisoning death associated with poison death. So you can see that we have, in terms of drug-related deaths, we have more than 2 a day in Ireland, tragically. At Liffey, just to give you some context about who we are and where we sit in what I'm about to explain to you in terms of this particular cluster of overdoses, nitazene overdoses. So at Liffey is a low threshold harm reduction organisation. That's our ethos. We don't bar people from our services. We find ways of working with people, engaging with them and supporting them. We provide services in Dublin City, Balbriggan, in North County Dublin, and in the Midwest region. The types of services that we deliver, this is not an exhaustive list, but just to give you a sense of it. The LAIR team, that's our law engagement and assisted recovery team. We take referrals from the Irish Police, the Gardaí, and we provide intensive case management services to people entrenched in street life. And that's important because it gives you a sense of the work we do with the police in Dublin, and the relationships that we have with the police here, the Gardaí. ACT, that is the private emergency accommodation case management team, and I'll talk again about that in a little while, because that was important in terms of this particular example. And again, it's a case management piece. And then community support, outreach, mobile overdose prevention, ASP, low threshold stabilisation groups, community detox, assessments for key working and case management, prison groups, etc. So harm reduction work on a street level. And then low threshold nursing. We have a nursing team who supply low threshold nursing supports, very inclusive nursing practices. So in terms of nitazenes, these are just 2 examples on the screen of warnings that the state put out, the HSE put out. And the first one on the left is from November 2023, when we had this particular cluster of overdoses. The one on the right is from June of this year. And the difference between the 2 there, I suppose, was, well, the first one was a huge learning curve for everybody. It was a powder substance believed to be heroin, and on the right it was street tablets, benzodiazepine tablets, which was again, a huge worry, finding that nitazenes had made their way into this into another element of the drugs market. So in November of 2023 in Dublin, there was the first one. December 2023, we saw another 20 overdoses, non-fatal overdoses in Cork, and in June 2024 we had this particular incident with tablets in Dublin, Galway, and the Midwest. So yeah, so it was serious. Like when this happens, and you'll see why in a minute. We average in Dublin maybe one or 2, maybe 3 overdoses across the city in a day, but you're going to see what happened to us in November of 2023. So yeah, I'll take you through that now. So this was the official warning from the HSE that was put out. The National Social Inclusion Office issued a risk communication to people who use heroin in Dublin region following a number of overdoses. That went out about midday, somewhere between midday and 2 o'clock. That was really, really helpful to drug services workers, because that meant that there was something backing us up in terms of what we were seeing on the ground. Before that midday, I was walking my dog at about 8:15 a.m. I got a call from Austin O'Carroll, a doctor based in Dublin, who was working in a clinic, and he was dealing with an overdose. And the ambulance crew had said they had dealt with 7 that morning already. He put down the phone to me because he was dealing with something. And around 15 minutes later, I called him back, and he couldn't speak because he was dealing with his second one. So there was 9 already by about 8:30 in the morning, and it just kept going up. So you can see that that was a very serious situation. As the day unfolded, and as I say, this particular communication was sent out from the HSE, it became apparent that we had a very serious situation going on, and we needed to work together to respond and to save as many people's life as possible. And I'll tell you what we did. So by Friday, the HSE had updated the status of its warning on Friday, Friday the 10th of November, when it was confirmed through analysis conducted by Forensic Science Ireland that a trace amount of nitazene type substance was identified in a brown powder associated with Duffin overdose. And you can see that they went on to later on to identify what type of nitazene it was. They put out another risk warning to the across Dublin to the services. Where I suppose our outreach teams were on the streets in Dublin, continuing to pass the word of the overdoses on to peers, people who use drugs, hugely important in terms of getting the information out. They did a brilliant job of then informing their own social networks. So in terms of stakeholders, critically important in terms of getting information out. But realizing that this was more than just a 24-hour problem, we asked volunteers from our team at Liffey to work over the weekend. We don't normally work over the weekend, but hands shot up. People realised the importance of this, and we put out for staff over Saturday and Sunday to help keep the messaging going and to put up fly posts and all sorts of things to do any way to communicate the risk and further interventions. So as I say, heading into that weekend, we knew that we had a problem. As the weekend progressed, the HSE were able to provide us with additional data from hospitals, which we again passed on to peers to complete the communication circle. Those peers gave us whatever information they had about the overdoses they knew of. If someone said a lad called Chris had OD'd last night in such and such a street, we'd go up around that area, find out whatever we could, and feed that information back to the HSE. It wasn't necessarily scientific data, but it was crucial in building up a clear, constantly evolving picture of what was going on. So we were intelligence gathering. We were gathering information from the ground up, and we were sharing it at a national level. We also worked closely throughout the nitazene overdose cluster with the Gardaí, the Irish police, who, among other things, helped with our taking of samples. If somebody had overdosed on the street or in a hostel, and it was possible to access a sample from that person, the partner or a worker, the Gardaí would then get it as quickly as possible to the HSE for analysis. It was an example of just how closely and effectively the HSE, and Garda Síochána and other stakeholders work together. The Department of Health, for example, were very supportive at a macro level, and we kept them informed. And over the weekend, the total number of overdoses for that period rose to 57. You can see that in the initial 24 hours, there were 34 overdoses. It made national news. You can see from the picture on the left, warnings were put on Friday, Thursdays, I think it was Friday evening actually, where people driving home and commuting home were warned on road signs of an extreme overdose risk as people went home from work, which was totally unheard of. And the city council supported these kind of measures. So we in terms of I should have mentioned, naloxone was a huge benefit throughout this weekend, getting it into people's hands, training them quickly, and making sure people knew how to use naloxone, and obviously call ambulances and what to do in an emergency was the messaging really for people. So, but after that weekend, there was a lot of planning and work across multiple agencies that went into how we might respond. We knew that this wasn't going to be a one-off. And when you think about it, in the build up to this weekend, we had foresight. We knew that the crop in Afghanistan had been destroyed. The opium crop had been destroyed. Opium poppy crop had been destroyed by the Taliban. We knew that 90% of the crop was gone. That something was going to happen, and that it was an obvious guess that nitazenes would play a role in this, or synthetic opioids would play a role in it. We didn't realise what it might be. We were worried about fentanyls, but it actually was nitazenes, which are, as Rita said at the beginning, are actually more harmful, more toxic. So huge issue. But just to give you an example of what we did in the days afterwards. So over the next 5 days, private emergency accommodation is a response to homelessness in Dublin, and we work in those services, so providing case management, as I mentioned. And over 5 days, from Tuesday the 14th of November onwards, Anna Liffey provided 327 private emergency accommodation staff with overdose and naloxone training, and further ensured that naloxone was readily available in the 54 private emergency accommodation locations across Dublin, which houses 3,500 people who were within homeless singles and couples. So we know that those in the weeks and months that followed, that naloxone was being used, and ambulances obviously were being called, and that people were much more aware professionals were much more aware of overdose risks and how to manage them, and they felt much more confident in managing the overdoses that would continue. I mean, this was a cluster. Nitazenes didn't go away, and as I said, we have had experiences since. Last week in Portlaoise prison in the Midlands of Ireland, there were 12 people taken from the prison having overdosed. We thought it was nitazenes, but it was a synthetic benzodiazepine that had never been seen before. So synthetic drugs are going to be a huge, we expect them to be a huge difficulty for us going forwards as they change and such. So yeah, I think we really need to use the foresight we have and implement as much as we can in advance of future problems. So my take-home messages would be: perfection is the enemy of the good. We're not that far removed from the COVID experience. I liked this quote from Dr. Mike Ryan: "Be fast, have no regrets. If you need to be right before you move, you will never win. Perfection is the enemy of the good. Speed trumps perfection. Everyone is afraid of the consequence of error, but the greatest error is not to move." And in that moment in November of last year, that came to mind. We had to move quickly, and we had to do what we thought would work. Yeah, I suppose that's what we did collectively in Dublin, the stakeholders, the peers, ourselves, NGOs, Liffey and others, the Gardaí, the City Council, the HSE. We all worked together, and we saved people's lives, there's no doubt about that. I think just to say to you, value equally the informal and formal data collection and communication structures as things that unfold. And naloxone, it does work, and it does save people's lives. So that's a photograph of naloxone on my desk in the office, and there's some details if people want. That's helpful.
Great. Thanks so much, Tony. We'll move towards questions at the end. We'll move on with the next presentation and collate a bit of a discussion once we've seen all presenters. Next up, we have Chris Rintle, who is Head of Harm Reduction at Cranston, which is a harm reduction and social justice charity providing support services across England. Prior to Chris's time at Cranston, he also worked as a social worker for 25 years in Belfast and in drug treatment and homelessness services, with a special interest and expertise in harm reduction, overdose responses in particular. And over the span of his career has written lots of practice guides and academic articles and set up harm reduction services and spoken at conferences around the world. Also delivering and developing and delivering specialist training across UK and Ireland since 2007. So with that level of expertise in the space, we'd be delighted to hear from you, Chris. Thanks for your time at this very early morning for yourself and Tony, fairly early time in the morning. And I'll throw over to you to share and kick it off when you're ready.
Thanks, thanks, Rita, and thanks to the Penington Institute for the invite to speak. Also great to hear from Tony about the amazing response in Dublin last November. I live just a little bit up north in Belfast, and it was obvious that things were moving at a pace, but the response was really unbelievable. It's a really good example of what needs to happen going forward in other places as well. So with that, I am going to try and share my screen. It may not be immediately successful, so bear with me. Thank you all. My name is Chris Van Tula. I work for Cranston, which has a range of different services across England, mostly drug treatment, but increasingly a lot of domestic abuse services as well. So my role is as head of harm reduction. What I'm going to talk about this morning or this evening, the key points are going to be around prevalence of nitazenes and drug-related deaths in the UK. That it is not just a heroin thing, although we shouldn't forget heroin as well as being one of the key drugs that it tends to contaminate. Talk briefly around naloxone and overdose messaging, and then about some collaborative work that was done in the UK with others and other organisations around staying alive, plan to stay alive. And then I'll close with a couple of key thoughts that I think are important for workers across the UK and our workers in particular to help keep this in focus and make sure that we're doing the right things. So there are obviously a range of nitazenes, most of which I can't even pronounce, never mind spell. So the two that we're seeing are isotonitazene and metonitazene as well. So, and the reason we know that, or the information we have so far to tell us that, is that nearly all of the detections by WEDINOS, which is the Welsh Emerging Drugs Information Network, which is based in Wales, but actually is accessed by all 4 UK countries, including England as well. Most of the detections have been those two nitazenes up top on the slide. And of these two, it's metonitazene, which is the one which is far more common in these road salts that we have. So these are the two that we have seen most of, and we have focused most of our attention in terms of what to do about them. So deaths involving nitazenes in England and Wales, there was a spike in overdoses and sadly also overdose deaths in and around the Midlands area in England. For those of you who aren't familiar with England, the West Midlands is the main city in there is Birmingham, and actually it was the epicenter of the deaths involving nitazenes last year, particularly around the early summertime. So what do we know in terms of the second half of 2023? These were the deaths in various different parts of England, and you'll see that the West Midlands that there were 17. As well as this, there's other information that we have. So by December 2023, there were 25 deaths in Scotland. And the National Crime Agency for the UK has recently published that there are 230 deaths linked to nitazenes from the 1st of June 2023 to the 1st of June 2024 across the UK. However, bad and all as these figures are, the situation may actually be a little bit worse. It's possible that not all deaths involving nitazenes are actually tested for, because there was no reason or no suspicion that nitazenes may have been involved in the death, and therefore it could be an underestimation in terms of the numbers of deaths. And there have been some concerns that some have raised that if somebody has died a number of hours previously to the testing, commencing, that it may not be able to detect nitazenes as being involved in that death. So what do they look like? Here's some pictures which show nitazenes in various forms. And I guess that the main point that I want to make here is they look very much like lots of other drugs that come in pill or powder form. And as a result, they can be added to or even replace a wide range of various different drugs without consumers ever knowing. In summer 2023, Cranston and other organizations, we began to receive reports from people using services of a very strong heroin, that's what it was kind of known as at that time, that was rapidly causing overdose and had an unusual smell or taste or texture around differently in foil if it was being chased, or when it was being cooked up, it behaved differently when it was being cooked up for injection. So quite a few people mentioned a red color and a sweet taste. And that in itself was a bit hard to kind of work out what that actually meant, because we didn't know what the smell or taste or behavior of nitazenes would be if they were within drugs. So we thought that nitazenes had been added to this particular batch of drugs, which had this sort of smell and taste to it. And then we kind of, reversed back and started to think, well, what might cause that? And we thought actually that's probably mannitol. So mannitol is a drug which is frequently enough added to heroin in the UK and some other drugs as well. And mannitol, interestingly, it's a sweetener, but it's also a medication. And when you see mannitol in normal heroin, it's at such a low level, really, that it's not detectable. People won't notice the smell or the taste or that red color. But if, for example, you have padded out some heroin with a little bit of nitazene, but you want to bulk that out, then you might add quite a bit more mannitol, by which time it becomes observable or noticeable. So what we kind of started to think was that we need to check, is there differences in the drugs, and not necessarily assume that the difference was about a nitazene being added, that you detect something about the properties of nitazene. It was more that you could detect the properties of the filler or the bulking agent, in which case, in this case, it was mannitol. So we started to ask people to watch out for drugs which had a strong effect and behave differently in a whole range of different ways, anything at all. And we started to get back more and more quality information, which started to help us give better advice and offer better solutions to people who were at risk of overdosing with these drugs. So on another point of the visual appearances of nitazenes, Tony mentioned that a little earlier there. Where I'm from actually is I'm Northern Ireland, slightly up the road from the Republic where Tony's speaking from. And here we found that there was a lot of benzodiazepines that were being contaminated with nitazenes. And a lot of the people that were using those would not have had any opioid tolerance at all. And the other problem for here is that people tend to take them in handfuls rather than one or two or three. So you could potentially have somebody that had taken 50 blue tablets that they thought was Xanax or alprazolam or even diazepam, never would be, but also contained nitazenes as well. Now, what the concerns are here is, although overdoses involving benzodiazepines or illicit benzodiazepines which are being contaminated will occur more slowly because they haven't been injected or smoked, the potency of the nitazene that was contained within them and the quantity of tablets that the person had taken was leading to overdose. And oftentimes it was with people with no opioid tolerance. And the reason for benzodiazepines being such a concern for people in my part of the UK is because of the historic use of benzodiazepines from the 60s onwards to manage the anxiety of, well, whole communities who were in conflict for decades. And so the overprescribing the benzos in Northern Ireland versus the rest of the UK was quite extreme, actually. And in recent years, that prescribing has been curtailed, and unfortunately, nobody has found a way of trying to make a safer supply of benzodiazepines within the UK, particularly, I would say, in Northern Ireland and Scotland, where they're much more prevalent and cause much more harm. So also on the slide then, nitazenes have been found in a range of drugs throughout the UK, similar to what Tony was describing there, not only in heroin, but also in the fake oxycodone tablets, which was quite a feature for a while last year, in THC vapes very occasionally, and a range of other illicit benzos. So wet-nos testing is now showing a shift from their addition to heroin to their addition to illicit benzos. And the concern here is the illicit benzos are often used by a different population. Heroin users may well use illicit benzos as well, but often you're having people that are using illicit benzos who have no experience with heroin. And if that is the case, they may be unaware of the risk of overdose with nitazenes having contaminated their benzos that they've bought. So making people aware of the risk of overdose was crucial. So as treatment services, we kind of asked ourselves, well, what can we do better? And there's a number of things, none of which are rocket science. I think we all probably know what they are already. We need to provide upstream drug checking, i.e. testing the drug before it's used, rather than after it's used, or remnants would be really, really helpful to do. And if we had legal mechanisms by which we could easily do that, we would do that instantly, I would say. Widespread naloxone distribution to reach saturation point of naloxone in the communities and the areas and the places that people who overdose may be. But one little point on naloxone I'd like to make is that we don't want to get to a point where naloxone is kind of weaponized, or that it's deemed by people who might be given naloxone or have naloxone administered to them as it being done punitively. So I'll talk a little bit more about that in the next few slides there, but I think we need just to be aware about the perception of people who use drugs who may be heroin dependent and are therefore possibly going to be given naloxone at some point in time if they overdose. Their perception of the effect of that and the perception of the reason for that happening and the dose that might be used may be seen in a way that could suggest to the person that they don't want to be anywhere near any service that is known to administer naloxone, because they're just going to put you into a rat hole and you feel miserable for ages. And that may be to do with dose or dose titration over a period of minutes after an overdose is discovered. Next point then would be about getting opioid users into treatment at levels of opioid substitution which provide therapeutic benefit. One of the key phrases that kind of shaped my thinking, especially since I've come to work in England or for an English organization, is somebody had said, I don't want your poxy 40 mils of meth, speaking of methadone. And I think that really helped me to see how treatment could be perceived by people who use drugs. And it's quite telling in terms of the doses of methadone that may be used, which may be far too low to provide therapeutic benefit to people. And also that protective or more protective plateau of opioid tolerance. Overdose prevention facilities would also be a great addition. It's great that Dublin's getting one. It's absolutely fantastic. Glasgow's getting one, but don't forget the rest of the UK, and in fact, the rest of the world. There are many places, including places that our services operate in England, that would very much benefit from some form of OPC. And lastly, for those who don't get any benefit from traditional OST, buprenorphine and methadone, diamorphine-assisted treatment would be very helpful. Okay, so back to naloxone then. I think I noticed a question in the Q&A section before when Tony was speaking there. And I have to say, in my opinion, we don't need a super strength naloxone. We don't need a 4 or 8 milligram nasal spray, etc. What we need is one dose every 2 to 3 minutes and go with effect then. It's a problem, I guess, that we don't want to be putting people into such a rattle, giving them such a high dose of naloxone. Yes, they've survived, but the perception that they'll be left with will be that it's been used punitively or it's been very unpleasant, etc. So therefore, the person self-selects out of services where they think that might happen to them some other time. So one dose every 2 to 3 minutes should keep the person alive, restore normal breathing, and may even restore the person to full consciousness, if that's the aim. But against that, overdoses in the UK involving nitazenes have tended to reoccur. That's what we found anyway. So the person starts to, or given naloxone, breathes normally for a period of time, and then starts to re-overdose again, requiring more naloxone. Again, at that kind of more gradual kind of approach to redosing. So whilst I don't think we need super strength naloxone, we may need more naloxone overall to treat the person, but over a longer period of time, because they may well re-overdose. And overdoses involving metanizing tend to have a higher chance of causing cardiac arrest than the other ones, and therefore CPR is needed alongside naloxone. Not enough time to go into it here now, but it'd be my opinion that within England there hasn't been enough focus on CPR and other supportive care alongside the administration of naloxone when it comes to the training, and that could be improved in line with how it's done in Northern Ireland and Scotland and Wales, where there are national programs and there's standards that are kind of set for training, which include quite a bit of focus on CPR for those unfortunate and rare cases where it's also required. So classic OD messages, I have 5 here. Everybody will have heard them and seen them before. They're well-meaning and they may help in some circumstances, but I'm not really overly convinced that they're really all that's needed. I think that we also need to kind of utilize the knowledge of a person who has of a scenario that they may overdose or they've overdosed in before, to be able to try to get that kind of thinking or in touch with that kind of thinking. What is it that you know about overdoses, if one should occur, that we don't know, that you might be able to plan for how to prevent yourself having a fatal outcome or an unwanted outcome if you should overdose again. So one thing around overdose, great to do prevention work, but we also need to get people thinking about what you actually do if you do overdose, what might happen, what might help. So in partnership with range of other people within the UK drug treatment sector, I guess, who have similar roles as myself as National Harm Reduction Leads, normally known as, I guess, we started to think about, well, what if we help people to make plans? And we call that staying alive. And that was based on this thinking about, you know, if somebody should overdose, what might they be able to think about previous to that might help us to prevent loss of their life. So we recognize that a person at risk is the only one who know their exact circumstances at that time or have a reasonable good idea of what they'll be, and therefore how to make a staying alive plan specifically for that occasion. So say, for example, before I have a hit, so you can make a plan saying, before I have a hit, I'll text my mate, leave a key under the mat at the back door, tell him to text me in 10 minutes. And if I don't reply, to come around and check on me. So not very difficult stuff, but that's the sort of stuff we need to get people thinking about. So my thanks are to colleagues in HIT, Lucy and Matty O'Hare, John Finlay and Humankind, to Deb Hussey and Turning Point, and to Peter Furlong and CGL, who we worked on this together last year. So my parting thoughts, I guess, what if workers in the field, or what your role is, I guess, who have access to people who use drugs, what if we have 2 things in mind every time we have somebody with us or we go to see somebody? How can I ensure that this person comes back to see me, or I'm able to get back to see them? And that's kind of pointing to the quality of the relationship or the therapeutic alliance that you're able to build up with the person, which is our bread and butter. We should be good at doing that, but we need to see it in the context of overdose as well. And alongside that, how do I ensure that that person is alive in order for me to be able to do so? And of course, that's pointing towards making plans with people, those staying alive plans. And if those were the first thoughts and things that are front and center of our minds as workers, then we have a far better chance. Well, firstly, we will have a better chance of preventing overdose, we're being able to respond better to it. But also it keeps us tuned in to the risk, because one of the things I think that might be occurring in places is now there's a little bit of apathy towards, well, it's been all over the place, it's, yeah, okay, so not quite the attention to detail or attention to the risk, sorry, that we should have. And finally, just to acknowledge my colleague, Philippe Bonnet, for several of the slides that I've shown this afternoon, and to my peers, the aforementioned National Harm Reduction Leads and HIT in the UK.
Wonderful. Thank you so much, Chris. Some really great insights shared there that I think we'll pick up again in the panel chat when we've got a moment to do so. Appreciate that very, very much. Before we do that though, next we've got Catherine Izawadi, who is our final speaker for this afternoon / morning, depending where you are. Catherine is an emergency physician and clinical toxicologist based in Brisbane, Queensland, and is the director of the Princess Alexandra Hospital Clinical Toxicology Unit, as well as being the medical director of the Queensland Poisons Information Centre, and the president of the Toxicology and Poisoning Network Australasia. So Catherine's an enthusiastic clinical researcher, and her interests include the management of illicit drug poisoning, the pharmacokinetics and pharmacodynamics of drugs in overdose, as well as snake envenomation, and currently undertaking a PhD titled Opioid Overdose and its Reversal through the University of Newcastle. So Catherine's going to speak to us about the emergence of nitazenes locally, clinical observations and experiences, and will be a great way to round up our chat for today. Ready when you are, Catherine. Thank you.
Thanks very much for that, and thanks very much for the invite to speak today. As explained, I'm a clinician, I'm an emergency physician, and look after poison patients, particularly when they come into hospital and have experienced more of the clinical side of things. And I was going to talk today about what the Australian experience is through emergency departments in patients presenting with nitazene exposures, and discuss a little bit about their clinical features, how they present, and then focus a little bit more on naloxone. I know there's been some questions that have been posted, and I'll give my perspective on that. Just to give a bit of a background, none of us have done it quite yet, but the nitazenes are synthetic opioids, as explained, and they all have this basic core benzimidazole structure on which there can be lots of different side chains. And depending on what those side chains are, affects how potent the substance is. All of them are more potent than morphine. In fact, they were synthesized back in the 50s in Switzerland, and they found that they were very potent mu opioid receptor agonists. But then they also found that perhaps they were a bit too potent. And in fact, many of them are more potent than fentanyl, which could put them, in the order of being 1,000 times more potent than morphine. And so that potency gives them a really narrow therapeutic window. So they were never ever explored as being used as therapeutic agents. But fascinatingly, even back in the 70s, it was predicted that nitazenes would be substances that could be used in the illicit market. And this is an opinion piece by someone published in Clinical Toxicology back in 1975. And he spoke about nitazenes being highly potent and clearly not productive in the clinical arena because of this, but a fertile field for the search of heroin substitutes, and would encourage illicit investigation. The first patient that I managed in Australia that had a nitazene-related exposure was back in February 2021. They'd bought some nitazene online. They'd used it intravenously. And when the ambulance arrived, they weren't breathing. They had a respiratory rate of 4. Their saturations were 80%. They received an intramuscular dose of naloxone, what our ambulance service gives standardly, which was 1.6 milligrams, and reversed their toxicity. They were observed for 6 hours uneventfully and discharged home. Back then, we didn't have any take-home naloxone to put in their hot little hand, but certainly that's something we always do now. Across Australia since 2022, there's been more and more nitazene detections, and this is in the clinical space, but also in the coronial space, that have led to the issuing of different drug alerts. So back in 2022, there were 3 alerts across Australia. And concerningly, in Victoria, it was being missold as ketamine, so people didn't even know that they were using an opioid. Whereas in New South Wales, it was found in heroin, or certainly something being sold as heroin. And in Canberra, it was in a counterfeit oxycodone tablet. Over the next year, there were more alerts across more states. In Queensland, we found it in fake Xanax, so counterfeit benzodiazepines. Distressingly, in those cases, they were coronial cases where people had used and succumbed to the nitazene. But other states were still finding, not only in opioids, but in non-opioid related seizures as well, that they were finding nitazenes. And in 2024, there's been 7 alerts so far, and now we're covering most of the country. And you can see that they're popping up still in counterfeit tapentadol, they're popping up in MDMA, in THC vapes, in counterfeit oxycodone. So it's coming across in lots of different substances. I thought I'd share some early data that we have from the EDNA study. So the EDNA study is the Emerging Drugs Network of Australia. It's a research project that was started out in Western Australia, and it was fortunate to receive really generous NHMRC funding such that we've been able to expand it across the country. So this is for patients who present to emergency departments with suspected illicit drug use, and they either have very severe toxicity or unexpected toxicity. So perhaps they thought they were using a stimulant but have opioid features, or they were very unwell with whatever they've used to come in. What happens is we store a sample of their blood and then perform comprehensive mass spectrometry to detect all of the compounds in their system, as well as any metabolites. And then we, into a database, put this data along with some information from what the patient believes is the drug that they took, what their clinical findings were in hospital, what happened to them, what treatment they had, and what their outcomes were. EDNA is across all states. We've been, over the last 4 years, gradually getting more and more states online. It started in Western Australia and South Australia, so the data's been there for the longest. Queensland came on back, I think, in 2021. Victoria was an early contributor as well, and they've actually managed to secure separate funding and have their own sort of standalone system, which is EDNAV, EDNA Victoria, that is going to be sustainable beyond the length of the study. And Tasmania has recently come online, and soon, hopefully, we'll get New South Wales online as well. To give an idea and to put into perspective how often or not often we're seeing nitazenes, over the 4 years with this data across the country, we've had 3,500 presentations contribute to the EDNA database. It's mostly young men who present via ambulance with high triage categories. And not surprisingly, given it's the Australian context, the main substance of use is methamphetamine, although GHB features prominently in about 1/3 of samples as well. And just going down that list there on the left, you can see that actually nitazenes aren't there on their own. So certainly they're separated within each separate number, so they don't quite hit the top 15. But I'll talk a little bit more to what we have seen on subsequent slides. So in that 4-year period across the states that you can see there in dark blue, we've had 32 presentations, about a quarter are male with a median age of 31 years. I think most concerningly, and it's been mentioned certainly with the UK experience, but it's certainly in the Australian experience, is people don't know they're using nitazenes. You have 16% of patients in this series, there were 5 of them, knew that they were using a nitazene or what they called a novel opioid. So a big chunk of people thought they were using opioids, other opioids, whether that was heroin or pharmaceuticals like oxycodone. Very concerningly to me, almost half of people who use nitazene in this series had no idea they're using an opioid at all. A large proportion thought they were using ketamine, they thought they were using cocaine, they thought they were using a THC vape, they thought they were using synthetic LSD. You know, there's what they did not think they were using was an opioid. So it's really concerning what's happening, and it would mean then that people who are looking after these patients, when they arrive in hospitals, aren't aware that they've taken nitazenes either. And I think that that impacts on how we've seen that this group has been treated as well. So what we found in this group of 32 was that most of them were protonitazene, followed by metanitazene, and in a small proportion, there were multiple nitazenes present. Interestingly, and probably again, not surprisingly, almost all of these exposures were polydrug exposures. A large proportion had co-used methamphetamine, although otherwise benzodiazepines featured highly as well. So, you know, synergistic sedatives being taken at the same time. So whether that was pharmaceuticals or with novel psychoactives, particularly bromazepam was one that featured. Despite the fact that almost all of them had other substances, including stimulants in their system, they presented with features typical of opioid toxicity. So they had, on a whole, small pupils and respiratory depression and coma. So the median respiratory rate was 8. The median GCS was 3. So, you know, 3/4 of the patients had coma on presentation. And naloxone was used in most of the patients who presented. We were talking about what doses would need to happen. So when we looked at this group and the total amount of IV naloxone, and I'll just talk in the terms of IV because it's difficult to compare the two, which is something I'll mention a bit further. But the median total dose was 300 micrograms. So that's not a large dose of naloxone. That's similar to the sorts of doses that we use in patients who present with heroin intoxication. 13% of patients went on to have a naloxone infusion. Again, that's similar to what we see with heroin. So looking at the way naloxone was used in this series, in this group of 32 patients, it was similar to how we see it used with other short-acting opioids. The intubation rate, though, was quite high. It was 31% in this group, which is something that's unusual for opioid intoxication when there is a readily available antidote. When you looked at that group, about half of them didn't receive any naloxone at all. And I suspect that might have been because there was no cue from history that an opioid was involved. But these patients were presenting with coma. And so they were intubated. Often half of those were in the field and half of them were in the emergency department. And of those, only 50% had doses of naloxone prior to intubation. But despite the fact that 1/3 of the patients were intubated in this series, they had quite short length of stays. So the median length of stay was 17 hours, which implies that actually with good supportive care, things turned around pretty quickly. And there were no deaths, fortunately, in this series. So to talk a little bit more about naloxone, and I know this question has come up through the chat, standard doses, as much as we can talk about standard doses, appear to be effective. It doesn't seem that you need to give very high doses. And I expect, certainly some of the information coming out of the United States where they report median doses of being in the 4 milligrams or 8 milligrams likely reflects that their route in the pre-hospital system is through the intranasal route, which will need bigger doses. And I'll explain on the next slide. And that these nitazenes tend to behave like other short-acting opioids. And when I say short-acting opioids, I'm talking about shorter half-life or immediate release preparations, as opposed to the longer half-life opioids like buprenorphine and methadone, or the modified release preparations like modified release oxycodone or tapentadol that often would need naloxone infusions and prolonged periods of observation because of the longer duration of action. The nitazenes seem to behave like a shorter acting opioid. And so I suspect most of the time when we're managing patients who come through the emergency department, we don't even know that there's a nitazene involved because they're behaving like other shorter acting opioids that come through. Keeping in mind that these are much more potent drugs and people are more likely to overdose on them. But if they don't know that they're using them, we'll just think they're like other shorter acting opioids that come through. To talk a little bit more about naloxone and particularly about at dose and route, it's not always the same when you're talking about the different routes of naloxone because of the bioavailability. So intravenous naloxone, which if you have IV access, certainly in emergency departments, we're taught to use a titrated low dose approach, is 100% bioavailable. All of the naloxone's getting into the patient and being able to be used, and it's very titratable. It's not always as practical an option in the pre-hospital setting. You might not be able to get IV access. You might not be able to you might have lay people who aren't clinically trained, to which point the ones available in the pre-hospital setting is intramuscular and intranasal. So intramuscular, and I'll just, those 3 panels of slides that you can see are, this is a pharmacokinetic paper. It's very clever. They did a volunteer study and were able to extrapolate sort of ideas about what the concentration of naloxone would be depending on with the time course. And you can see on the very left panel, it's IV. There are 3 lines. The lowermost is 400 mics of naloxone. The middle is 800 mics. The top is 2000 mics. Whereas the middle panel is intramuscular, where the lower one is 800 mics. The middle line is 1.6 milligrams and the top is 2.4. And you can see just by looking at that the bioavailability of intramuscular is probably somewhere between 40 and 50%. So even though the dose sounds higher, you're delivering sort of half the amount of naloxone for each dose that you're giving. And the other thing to note about the intramuscular dose is that it persists. It's still there and measurable at 4 hours. And that is one of the reasons why when you give an intramuscular dose of naloxone, it lasts longer and there's less likelihood that you get recurrence of toxicity. Whereas intranasal, which is an excellent option for the layperson and for people who are, family and friends of people who are using drugs, it's very low bioavailability. It's maybe 5 to 10%, and the duration of action is very short. So it's quite likely that you'll get recurrence of toxicity and it'll come back and you'll need to give further doses. But when we're talking about big doses like 2, 4, 6, as you can see there, so 4 milligrams, which is considered a very large dose of naloxone, is actually probably equivalent to, maybe something like 600 to 800 mics of IV, or maybe a milligram or so of IM. So it depends on what route you're talking about what the dose is. But if you're thinking overall, do nitazenes need higher doses of naloxone? I suspect that they don't. And the question goes to, and if you were going to put my hand behind my back and make me pick a favorite dose and route of naloxone, I prefer using intramuscular route because it persists and you're less likely to get recurrence of toxicity. And then I prefer the 1.6 milligram dose because you're more likely to get effective reversal in a single dose. So if I was to pick a dose that's going to work in the pre-hospital setting, that would be my preference. Although I do acknowledge that having a larger dose and putting a balance towards more effective reversal does increase your risk of precipitating withdrawal, which can have flow-on effects for people presenting with healthcare services in the future. However, and it is probably part of it is my clinical experience flavouring this, and I'm, at that real pointy end in the emergency departments, looking after people and talking to families of people who have awful hypoxic injuries and explaining how they're not going to survive. My focus is always more towards establishing breathing and preventing hypoxic injury, which is why I do err more towards the effectiveness of naloxone, and I want to reverse respiratory depression when it's there. So my take homes for the Australian experience of nitazenes is that people don't know they're using them. Sure, half of the people who are using them think they're using an opioid. There is a big chunk of people who aren't even aware that there's an opioid being used at all. And that has huge implications from a harm minimisation perspective. Almost all of these are part of polydrug exposures. And even then, the opioid toxicity is coming through and we're seeing it. And I suspect that's because these are such potent agents. As a whole, they tend to behave like shorter acting opioids. And the standard doses of naloxone that we would be using for other shorter acting opioids appears to be effective. So that is me.
Amazing. So much content covered in such a short space of time. Thanks again to all 3 of you for your generosity in time putting this together and being available to answer questions. I just want to encourage everyone again that if you do have a question, use the Q&A function in the webinar, the Q&A button, I should say, in the webinar, and we'll get to them. There's a bit of a theme here, guys. I'm going to try and do it with some sort of order. We've got about 20-25 minutes to have a bit of a conversation about some of the things that have come up. Lots and lots of questions about naloxone. I might pick that up just because that's where we left off. So I might start, Catherine, or actually open up to all of the panel. If people are administering a naloxone in the field, they've obviously likely to have called an ambulance and they're waiting for an ambulance. Do you have any recommendations? Obviously, most people are carrying Nixoid these days in the community, and that's usually the preferred method. Any recommendations there that people can enact when they're, in that situation?
I'm just looking at the very last comment there regarding 2 Nixoids while we're waiting. I don't think you need to give 2 up front. I think what you need to do is get naloxone into the patient with whichever method that you have available to you. If Nixoid is your method, give a dose of Nixoid and see the response. What we are seeing is that usual or standard dosing is working. It's just that certainly with intranasal, it's very likely that they'll get recurrence of toxicity, which is okay because you've got the ambulance on the way. So I'd keep that second dose if they needed it. But I would definitely be using that first dose of naloxone. If I had pranoxad, which is obviously the other one, my personal opinion is to give 1.6, but I can understand that that other people give different doses, give titrated doses, maybe 400 mics at a time, which is certainly what the pranoxad container does say. But I always err on trying to reestablish breathing. I don't use this in people who aren't not breathing. I use this when people aren't breathing and when their life's at risk, and I want to get them breathing again. And we recently did a randomized controlled trial looking at a larger dose intramuscularly, so 1.6 intramuscular versus titrated 100 mic IV. And there was a trend, it wasn't statistically significant, but there was a trend towards increased withdrawal. So, it may, and it probably will, because you're giving a larger amount of naloxone, increase withdrawal. But, in my, when I'm working with people, and I apologize profusely when they wake up and explain that they weren't breathing, and I make them a cup of tea and I apologize and have a chat to them and try to see what I can do to make them feel better if they do have precipitated withdrawal. But I explain that I was really just trying to get them breathing again. And it's usually well received, recognizing obviously that people feel awful when they've got precipitated withdrawal.
I think that's really valuable, actually, acknowledging what somebody may be going through and just creating a space for some supportive care post recurrence of breathing. Did the Chris or Tony have any comments to make with regard to that?
I'd like to, because it's very interesting hearing from Catherine in the kind of the hospital setting, and my experience is more in the pre-hospital setting, where I community and streets and so on and so forth. And I guess that, well, there's a couple of things I mentioned earlier about the lack of quality training, or there is sometimes a lack of quality training. And I absolutely get, if somebody is not breathing, most of the time in a pre-hospital setting, you're going to be that panicked, you're going to stick in 2 milligrams of naloxone instantly, particularly if somebody's blue. It's maybe not ideal, but it's a hell of a lot better than the person dying or having that hypoxic brain injury that Catherine was talking about. But in general, if there is good supportive care alongside giving graduated doses of naloxone in an intramuscular fashion, because we basically have made a decision as an organisation that for now, with the risk of the nitazenes, we want people to take pranoxad unless they're not allowed to take it by their employer, perhaps like a police officer or something like that, or they're unwilling to take it. But we definitely at this point in time are preferring to supply pranoxad to people because it has advantages in that dose titration, etc. But the point about CPR is that there is that argument, and there's different views and things like that around, do you give chest compressions, do you give rescue breaths, do you give both? My opinion is that the optimal chance of somebody surviving, if they're not breathing normally, is that you give the combination of rescue breaths, chest compressions, and naloxone at 400 microgram intervals 2 to 3 minutes apart, and that gives that optimal chance. And we don't deviate from that in our training, and we spend quite a bit of time talking people through and showing them and getting them to practice giving good quality chest compressions and good quality rescue breaths as well. And we believe that that will have the best chance of counteracting the risk of death when nitazenes are involved.
Thanks, Chris. You actually preempted my next follow-on question. So that's brilliant. Tony, early on we got a bit of a question, and I guess this is actually for both of you, Tony and Chris, around the bureaucracy in getting access to take-home naloxone. I understand there is take-home naloxone definitely in Ireland as well. I think so as well in the UK. Yeah.
It's complicated. It's still a prescribed drug. It's a drug that's prescribed to the individual, and should be held by the individual. The irony of that, when you're overdosing. But like we've had to get workarounds. You know, we make sure that naloxone is on site in private emergency accommodation, and then when it's been administered, we record who it was administered to. Yeah, no, it should be rescheduled. It should be over the counter. That's what we've been asking for years. We want to see that still happen. There should be as little barriers to getting your hands on naloxone as possible, intranasal, intramuscular. You know, in a way, if as we go forward, and you know, and if with as I suspect, we will see nitazenes and other synthetic drugs, particularly opioids, entering into other parts of the market. We will need naloxone more and more, and we will need it as you know, perhaps not as commonly as a condom in your pocket, you know, but certainly that people who are going out for the evening should have this to hand. You know, there is, you know, I'm not one for a moral panic, but I'm very, very concerned what the future holds when it comes to synthetic opioids.
I think you echo a lot of concerns that many of us are actually having. It's true. And I think specifically getting the messaging out there to people who may not normally be the target audience for naloxone messaging and campaigning. Chris, I'm really, I think there's a lot of value in changing some of the messaging that we have. And you spoke to, you know, having people mentally prepare ahead, not just knowing that they've got naloxone in the pocket or in the first aid kit or wherever it might be, but actually having a strategy, because even the steps in doing that just makes people more aware, and it brings everybody in on what will happen. And I think that's the reason we do, you know, is the reason we do fire drills. It's so that people in an emergency can just kick into the plan mode rather than panic mode. I think there's a lot of value in that. A couple of questions that have crossed my mind and have come up are asking from the UK and the Irish experiences, are there things that you wish you had have known or access to processes that you might have done differently, knowing what you know now, as a little bit of a foresight for what we could be focusing on and targeting in Australia, moving into?
I would just say there's a simple answer to that from my perspective, is to do what Dublin did and what Tony described. If you see, because the reason that you'll know it's nitazenes, well, it'll obviously have to be confirmed by testing later, but the reason you really know something's happening is you get multiple overdoses in a short period of time. And so when that happens, you need to be able to respond. And so everything that Tony talked about, what they did in Dublin in November last year, is really, for me, the gold standard. So I'll stop talking. I'll let Tony take that.
Having led the march on the gold standard, Tony, is there anything that you would like to share or any reflections you have?
Well, you know, I mean, no area, no jurisdiction gets everything right. You know, like you go to different jurisdictions, and you know, we don't have drug checking in Dublin city centre. We have back of house drug checking at some festivals in the summer, but we don't have drug checking in Ireland. Obviously, we worked with the guards and with the HSE to get as much knowledge, and it was good. You know, it was good, but there's always improvements to be made. You know, I know we haven't talked about these yet, but you know, nitazene strips. We don't use. Well, sorry, the HSE are quite clear. The Health Service Executive in Ireland are really looking at the effectiveness, the efficacy of nitazene strips, whether they're helpful or not. And there's different conversations going on in different jurisdictions about those strips. And like, we haven't been using them at the Liffey. And I'd be interested to hear what my colleagues, Chris or Catherine, have any thoughts on that. But there's, I suppose, in terms of your question, I mentioned it earlier. Solid communication, partnership work, getting as much information from the informal and formal, and just doing our best, by people, and really listening to the peers, really informing them, and tapping into their networks, because people don't want to die, right? They don't want to die. They go out and they purchase their drugs as they do normally, and this happens. It's not it's not intended.
Yeah, absolutely. And I think you also in your presentation touched on the point that not to get too caught up in getting it right and getting it perfect, just getting on with the job and doing what you can when you can is really valuable too.
Yeah.
In terms of people not necessarily having access to either at-home testing or formal drug checking and or pill testing services, there has been a lot of questions, and Chris, you've touched on it a little bit in that you talked about a discoloration and potential difference in how the substances might burn. Is there, other than obviously people experiencing multiple overdoses and it being very clear that there's something potent in the market, is there a way that people who do use drugs can determine or suspect if they've got nitazenes? You said it's sweet taste. I'm thinking of the information that's coming through from the community, from the peers, from the people with lived experience. Are there, and I'm appreciating that this is anecdotal information, but also we really are in a position where we potentially need to rely on anecdotal information and find ways to collect, gather that, and make decisions about what information is important to share. So I'm just wondering if you've got any insights or tips there, and the answer may just be flat out no.
Well, I guess what we did was we set up kind of an alert system across all our services in England. We asked people to report back to us through people that they work with anything unusual about something they'd taken. So we didn't limit it to heroin, although obviously we wanted people who use heroin to be part of that. And we weren't, I mean, I saw another question around mannitol. So mannitol was the medication I was talking about earlier that we think was bulking out heroin, because there had been some nitazene added to it at the time. So sorry, mine's just going blank. Apology. Where was it?
I think actually you touched on it, and this was a great point, was, the alert system. Having the alert system, and also being aware of what fillers are being in there, because obviously the nitazenes are happening at such low concentration. So that's information that we could be communicating to our workers, to communicate to community of things to keep an eye out for, that they could then be feeding back informally or formally. Yeah,
so one example of that was we got a report quite recently, actually, by somebody who had bought a 5-pound bag of what they thought was heroin. They were smoking, and they smoked it with a friend, and neither of them got past the second stripe, and they were out. And they were out for quite a considerable period of time. Now they describe themselves as being asleep, but I would describe that as overdose. So what they said, there was something unusual about the way it ran down the foil. I can't recall just off the top of my head what that was. So the two things happened. You had 2 overdoses, even though they wouldn't have been attended to. I don't believe naloxone was involved or any emergency care brought to the person. And you had them rapidly. I mean, normally first couple of lines down foil, it's just you're burning off the paracetamol, you're not getting any heroin at all. So in this case, 5-pound bag, 2 people smoking, both going over within 2 stripes, that something unusual is happening there. So you have to gather all that type of intelligence together, which may come from multiple sources, and try to interpret stuff on that. So my line would be, look, if you have something and it knocks the socks off you, tell us all about it. Tell us anything that you noticed about it that was unusual, and then go from there.
We're certainly encouraging workers that we're in contact with through some of the forums that we have to, start having those conversations and or recording information and then reporting it back to the wider group so that, if we are starting to see patterns, we see them sooner than later, and we don't have to wait for situations where clinicians like Catherine are responding in a hospital or, pre-hospital setting. There is a fair bit of interest in why anyone on the panel is welcome to answer why they think nitazenes are popping up in non-opioid drugs. Is it a matter of cross-contamination? Is there nefarious reasons? Do we have any answers to that question? And do we have any idea about where they're predominantly coming from at the moment? A tricky one to answer. Tony, you're on mute.
I can't imagine people want them to be popping up in non-opioid substances, because you can't imagine, as someone who might be doing this for a living and selling these substances, that you'd want harm to come from your clients. So I suspect that it might just be that we're catching people who are down the chain and aren't quite aware of what's in it. And there's no way. I know one of the comments was, is there a way of knowing by looking at it? There's no way of knowing by looking at these things, and particularly the counterfeit tablets can sometimes look really deceptively like the real thing. And so short of drug testing, which certainly in my state has only become a thing in recent months, you're really stuck. And it's the other things that are important: carry naloxone, make sure you're using with others. That is, I guess, the message that needs to be there. I would have no idea why you'd want to have a nitazene in a THC vaping product. It's mind-boggling. And these are the ones that we're seeing in the coronial cases. And I can't imagine why anyone would do that.
And it might not even occur to somebody that they're having an opioid overdose, so therefore might not seek, the adult flow-on effect from that. Are you seeing overseas nitazenes popping up in stimulants and other than, the benzos and opioid products that you've mentioned?
Very occasionally in the UK.
Yeah.
Very occasionally. So not so much in cocaine, although there have been a few reports of it. Definitely some cross-contamination, in my opinion. And certainly some laboratory testing in the Birmingham area has suggested that lots of drugs are contaminated with lots of nitazenes, but not in sufficient quantities to cause harm. One thing just I wanted to mention around sort of the tablets, and one of the pieces of advice that we can try and give to people, which isn't perfect, but it's better than nothing, is that if you're getting something for the first time, you don't know what it is, and you're concerned it might be something else, and you think that you're being sold something which is a legit medication, like a benzodiazepine, and it comes in whatever color, suck the color off, and if that underneath the color, the capsule covering, really, I suppose, or the capsule, the tablet covering, it goes a different color, goes to white or something else, then you're probably getting medication. But if you've just sucked a blue tablet and it doesn't, it's not just the covering which is blue, then you're probably looking at something which is illicit. It ain't a perfect solution, but it's one of the things that maybe, I guess, gets people to tune into the risk of contaminated drugs, particularly because the benzos do seem to be more and more contaminated with nitazenes.
Potential there that people could even use like a pill cutter or something else, and if it is sort of that that dyed all the way through, that's actually something I hadn't heard, so that's quite valuable. Just mindful of, we've only got about 5 minutes to go. Time flies when you are having a great learning experience, and so many more questions I would love to have the opportunity to ask and cover. That being said, I think potentially, I think it was you, Chris, who mentioned sort of implications for pharmacotherapy for people who might be using methadone, et cetera, Does anyone have any considerations? And Catherine, you might have clinical input here, although it's more on the treatment side rather than the emergency responding side. Any implications for pharmacotherapies and or dosing, and has there been any conversations overseas around reviewing treatment protocols in lieu of things like nitazenes, or if not, what would you like to be seeing happening, I guess, is a question. And I know that's a big can of worms and could be its own webinar.
It's interesting. We don't know they're taking them. So it's so hard when you're seeing people in the emergency department to think about that. So we try to always encourage and have that first discussion with people if they're not aware, although a lot of people have better understanding, particularly with the buprenorphine long-acting injectable that's available, about ways to start to address this and to get linked in with the system from an opioid substitution program perspective. So, you know, it's so difficult to apply it just in nitazenes because frankly, we don't know they're using them, you know, and we're not seeing the numbers so large at the moment that it's really pervasive through. We're still seeing small numbers, and most of those people don't know they're using them either. You know, 15% do. And so I think that a big chunk in certainly in Australia is we don't even know that the problem's there at the moment. And without having these sort of robust toxicovigilance systems, which we don't have also in Australia yet, you know, we're not going to know about it either. So it's a really tricky problem.
From a UK perspective, and particularly within England, my experience is it's getting people back into treatment who are heroin users, people who used to be in treatment, but in 2010, 2012, the UK decided to get rid of, well, pretty much dismantle harm reduction services across the nation in favour of recovery and abstinence. And it's been an unmitigated disaster. And the people at the most risk of overdose are the least likely to be in treatment. Getting people into treatment is protective for overdose, particularly if it's stable doses of substitute medication. And if they should overdose because they also take something unbeknown to them as a nitazene, it's protective against death. Now, it has to be at therapeutic levels, and certainly I think mostly it's pretty common to see in England anyway, subtherapeutic levels of methadone prescribing. And whilst depot buprenorphine, long-acting buprenorphine is an advantage in some respects, it also brings with it the concerns, certainly I have, about ongoing and increased injecting of stimulants. So people that have stopped injecting heroin completely, but are injecting coke 15 times a day, where they only injected heroin 2 or 3 times a day. So, you know, there's no wonder drug in this, but we need to look at a whole range of different options. But for me, it's get people into treatment and keep them in treatment, keep engaging with that person. That's mine.
Just echo that. I mean, you know, during periods of heroin droughts or periods where there's, you know, significant clusters of overdoses associated to opioids, synthetic opioids, you know, people do indicate that they want to get onto treatment. They want to get away from that risk. Not everybody, there's different responses, but you need to be ready to get people into treatment as quickly as possible, particularly opioid substitution therapy to stabilize people. And certainly in Ireland, during COVID, we managed to reduce the waiting time from a 12 to 13 week wait to a 2 to 3 day turnaround to get people in, and you know, generally we've maintained that. And you know, getting people into treatment, as Chris said, is really important. You know.
Absolutely. Absolutely. Mindful of time, we've hit the 5:30 mark. So I just want to take the opportunity to once again thank you all for your really valuable insights and for your time this afternoon, and remind everybody that we do have some other webinars coming up next week. One is on overdose in Australia, which will be the launch of the findings from our Australian annual overdose report for this year. And we will certainly be looking to pick up this conversation and continue it on as we keep watching what's happening overseas and locally here in Australia, and trying to support and encourage, you know, best practice responses as we go. So again, thanks everybody for your time spent with us today. We will encourage everybody to complete the feedback form, which will pop up at the end of the webinar, and for everybody to have a really wonderful afternoon and or rest of your day. And thanks again.
Thank you very much.
Thank you.